Hello, everybody. I'm Jenny LeRae, and welcome to today's Research America Alliance discussion. Thank you for joining us, and as always, for your partnership in the Research America Alliance. I'm going to start off with some housekeeping. If your organization isn't a member, I hope you'll reach out to my colleague, Kristen Furlong, who directs membership, and her email is in the chat. She can fill you in on all the wonderful things about being a member of our alliance. Well, it's a great pleasure to introduce our guest speaker, Dr. Christina Economos. She's the Dean of the Friedman School of Nutrition, Science, and Policy at Tufts University, and her bio is in the chat. We're going to focus our discussion with her today on the role of food as a nutritional and health intervention. She's going to share some data with us and provide some background information, and then we'll go into a Q&A session. So Christina, please take it away.
Thank you so much, Jenny, and thank you for having me today. It's a pleasure to be here, and I'm really excited to share some data with all of you and talk about the importance of food and nutrition, especially at this moment in time in our society. So I'm going to share my slides, and please get your questions ready because we will be moving into an interactive Q&A. Great. Jenny, can you confirm that these look okay?
Yes.
Great. Okay, so the title of my talk today is Food-Based Nutritional Interventions to Improve Health Outcomes. And as Jenny said, I'm the dean of the only school of nutrition in North America, where we have an incredible breadth of research that we do focused on food and nutrition from cell to society. So I want to start with how we're doing as a country in terms of our eating compared to the dietary recommendations or guidelines that we have in the US. So in this graph, you're seeing the percentage of the population that is below recommendations on the bottom, shown in blue, or above recommendations on the top, shown in purple. So starting on the left, we're looking at healthy foods like vegetables and fruits and whole grains, all the way over to dairy, meats, poultry, eggs, seafood. And you can see that as a whole in America, we are falling short of the recommendations to eat these healthy foods. I also want to point out something on here that's called refined grains. And you can see that we are going above the recommendation for refined grains. If we broke this down further into sodium and sugar and saturated fat, you'd see that we also fall far above the recommendation for those nutrients. So as a whole, the country is not meeting the dietary guidelines, and there's a lot of room for improvement. So why does this matter? It matters because what we eat results in a change in our health and an increase in chronic disease. So I'll start by showing you the current US overweight and obesity rates and where they are now and where they've been over the past decades. Going back to the 1960s, when we started systematically collecting height and weight data to calculate body mass index and actually determine the weight status of the population. So you can see on the left, on the x-axis, 1960 to 1962, we had obesity rates at about 10%. If you look at men, and if you look at women, it was about 15%. And if you follow that all the way over to the right at about 2017, 2018, you can see that those have continued to climb dramatically, with the biggest increase starting at about 1980. Now, if you look at the overweight data, which is in blue, solid is for men and dashed blue is for women, you can see that overweight was fairly steady and then it actually started to decline. And that was at the same time that obesity started to increase. So if you combine overweight and obesity rates for adults in the United States right now, it's more than 2/3 of the population. And what's really alarming is the orange lines that you see at the bottom, which represents severe obesity. These are individuals with a very high BMI, and those rates have been slower but steadily increasing over the past couple of decades. Now I want to show you where we are at the most recent data that we have, which was published for August 21 to August 23. And these are just adults, but here it's showing you by age and by sex, and this is just obesity. So if you focus first on the left, looking at total, you can see again, we're hovering on average now higher than 40%. And if you look at it by age, the prevalence rates are the highest in those between the ages of 40 and 59. And that holds true for men and for women. So we're really at a very critical time right now where some people believe that we've reached the peak and others believe there's still a ways to go. And that's shown here in these data, which are actually projecting out overweight and obesity through 2050. So the top two graphs are showing you females and males between 5 and 14 years of age. So these are young adolescents. The next two graphs below and in the middle are males and females between 15 and 24. And then the bottom two are showing you males and females 25 and higher. And what I really want you to focus on here is that on the bottom, you can see overweight and obesity separately, and then you actually see it combined. So let's just focus on the bottom adults right now, and that would be E and F. And you can see that we're projecting that the rates of obesity will continue to climb, whereas the rates of overweight will decrease. So we could possibly be headed for a population where almost 2/3 of the population have obesity. And this is really alarming. Now, we do have some really good interventions that have come on the market in the last few years in the form of things you often hear as GLP-1s. These are medications that are reducing overweight and obesity, and they've been very helpful for individuals. They're cost prohibitive for some. We haven't yet reached a point where all insurance is properly covering. There's a lot of questions out there around, is this a medication people will have to take forever, or are they able to wean off it? And if they are weaning off it, what are the physical activity and dietary guidelines that they need to adopt in order to maintain weight loss? So lots of questions, excellent research going on. But if we don't get this under control, we are potentially headed for an even worse state of health. So I also want to talk a little bit about diseases. So obesity is important for sure, and obesity is associated with a lot of chronic diseases. But we can look at disease independently as well with respect to consumption of food. So this is the proportional burden of type 2 diabetes attributable to suboptimal diet, but overall and suboptimal diet jointly and by each individual dietary factor. And this is global data from 2018. So on the x-axis on the bottom, you're looking at diabetes burden attributable to a suboptimal diet. And you can see overall a suboptimal diet contributes very, very, very much to the development of type 2 diabetes. And this is more adult onset, not juvenile diabetes. And if you look independently at each of the dietary factors, you can see insufficient intake of whole grains, excess intake of refined grains, which I actually showed you in the first slide. We have an excess consumption of refined grains and not enough whole grains. And then you go down to excess intake of processed meats, excess intake of unprocessed red meat, insufficient intake of yogurt, excess intake of sugar-sweetened beverages, etc. So each of these independently contribute, and when you put them together in a suboptimal diet, you have a very large contribution or likelihood of development of this disease. This is actually showing you, again, global data from 195 countries, mortality rate attributed to diet, and number of deaths at the global level attributed to diet. And so in the center, you again see dietary variables like diets high in sodium, diets low in whole grains, low in fruits, low in nuts and seeds, low in vegetables, going all the way down, really breaking down our diet into the different components that we know are important to maintaining health and to preventing disease. And what you're looking at here is that by country, and so what the authors have done here is they've actually divided the 195 countries into demographic and income data, so that the orange bars are representing high to middle countries, and the blue bars are representing low to middle socio-demographic income countries. So they're taking into account quite a number of variables to actually develop this, but we often think of this as high, middle, and low income countries. And so what you can see here is it does vary depending on the cluster of countries, but overwhelmingly, diets that are high in sodium and low in whole grains and low in vegetables have a larger contribution to mortality rate and to the number of deaths at the global level that are caused by cardiovascular disease, type 2 diabetes, and other causes. So these data are really confirming that what we eat has a direct impact on disease and longevity. So the other point I want to make is how much we spend. U.S. healthcare expenditures reached 4.9 trillion in 2003. We spend an enormous amount of money on healthcare, and estimates are that about a quarter of this is preventable diseases that are linked to diet. So we know that if we improve diet, we could reduce the outcomes and we could reduce the healthcare spending. So the goal here is to provide an optimal diet for all Americans, regardless of geography and income and age, et cetera, so that we can help with quality of life, reduction of disease, and decreased spending. So how are we going to do this? This is a very simple model that just breaks down food-based interventions at multiple levels. And I'll start with the individual. There are lots of interventions that we conduct focused on individuals, and these include things like medically tailored meals and produce prescriptions, which I'll talk more about in a moment. We're delivering individual food to people. Then at the next level of interpersonal, we have interventions focused on families and social networks, such as those focused on family meals or community meals. The next level is community, where we focus on local food systems and access to resources, such as developing community farms, establishing farmers markets. Then we move out to organizational, interventions focused on schools, workplaces, and other institutions, such as implementing school gardens. And then the last one is probably the biggest lever we have in this country, and it's policy. And we can think of policy at the national level, such as working on the Farm Bill, which has our SNAP program, the Supplemental Nutrition Assistance Program, or our GusNet program, which provides incentives for people to buy more fruits and vegetables. And these policy decisions that are at the national level involve Congress, appropriate and provide money to the state and local level, really go a long way to promoting healthy food environments, such as subsidies and programming for the consumption of fruits and vegetables, and even lowering nutrients that we know we're getting too much of, like sodium and sugar. So we have a lot of different strategies where we can impact what people are consuming. And I know there are a lot of questions that have come in that we'll discuss on how we can think about this, but it is complex. It's not just telling people to eat better. It's policy, it's fiscal strategies, it's education, and it is society really making the decision that we're going to value good nutrition for all. So I'll talk more about that in a moment, but I want to introduce food as medicine, which is a topic that many of us are focused on right now. It has bipartisan support. And this is really thinking more specifically about how do we get food to people to prevent, which you see at the bottom of the pyramid, and to treat. So it goes beyond just public health prevention programs, and it starts to talk about how do we help people who already have disease receive adequate treatment that might include pharmacology and surgery and healthcare, and also good nutrition. So I'll start at the bottom with prevention. I've talked a little bit about population level healthy food policies and programs already, and this includes our SNAP, Supplemental Nutrition Program, and how we actually think about that at the population level. But it also includes just general dietary guidelines that we produce for Americans. And those are actually absorbed into many institutions that make decisions about what to purchase and what to serve the populations that are part of those institutions. Going into true nutrition security is where we have SNAP and we have our WIC program, Women, Infants, and Children's, our school meals program that includes breakfast, lunch, and snacks for children, our Meals on Wheels program, which is an elderly feeding program. And this is really ensuring, using the dietary guidelines, that we provide healthy food for all who are part of those programs. And if we're doing that well, we should be preventing chronic disease. Now, moving into treatment, there are new programs that are being experimented with across the country, and these include produce prescription. So when someone arrives at a healthcare visit, they may receive a prescription to get produce once a week, once a month, where they can start to incorporate it more into their diet and learn how to cook and actually increase the value of their diet. Then there are medically tailored groceries, which might include low sodium products, high fiber products. And then there are medically tailored meals. And these are actual meals that are prepared that are very useful for people who are in rehab, who are going through chemotherapy, who may be disabled from their disease, who can't actually cook for themselves, but really need to be treated with a medically tailored meal. So this is a really exciting area of research. I mentioned that there's bipartisan support for a lot of this. And I want to just tell you a little bit about how the public is responding to this. So this is a recent study that was published by my colleague, Ronit Ritberg at Tufts. And they really looked at the national knowledge and interest in these food as medicine programs. And they divided the population who answered by food security and nutrition security status. So we'll just look at the bottom two rows going across when you combine people who are food and nutrition, either insecure or secure. And what you can see overall is that the knowledge level of medically tailored meals and groceries and produce prescriptions is about really a quarter of the population or a fifth of the population. But when you ask people if they're interested in participating, it goes up to about 2/3. So this is really promising to look at people's interest in eating healthier and taking advantage of programming that might be available to them through healthcare. We also know from a lot of research that's been published in the last couple of years that improvements in health outcomes, including things like hemoglobin A1C, body mass index, blood pressure, reductions in heart failure readmissions, reduction in depressive scores, and overall increases in diet quality, including fruit and vegetable consumption, has resulted from these food as medicine interventions. And one study estimated that national implementation of food as medicine in Medicare, Medicaid, and private insurance could avert 1.6 million hospitalizations and result in net savings of 13.6 billion in healthcare costs in the first year alone. So this is a lot of modeling that's being done off these pilot studies to really understand what if this was spread across the population, what could this do in terms of healthcare savings? And real-world data from a major healthcare institution found that providing high-risk patients with medically tailored meals for 3 months significantly reduced emergency department visits and hospitalizations, with healthcare savings of over $12,000 per person. So we know that the studies being done have shown a lot of benefit, and we're continuing to conduct those studies, to publicize the results, to share them with policymakers, and hopefully have some good success in the next couple of years helping the population eat healthier. So this is a study I'm conducting, and I wanted to share it with you because it's a pretty comprehensive study that brings together a lot of different disciplines and elements of food as medicine. It's called Delta Greens, and it's a collaborative community-based produce prescription approach. And the aim of this study is to design a novel food as medicine intervention that bolsters the local food economy and delivers food as medicine programming to a low-income rural population. And the reason we're doing this is because we get our food from across the globe, as you all know, and it's beneficial to produce food locally because it helps with workforce development and it helps to ensure we're getting fresh food without it traveling a lot of miles. So this is a study that really has an economic component as well as a health component. So we're working with farmers in a rural area to help them scale up their production of fruits and vegetables, increase workforce opportunities, and deliver that to a population that's at high risk of disease. And so we are recruiting individuals for a randomized controlled trial. We're measuring things like hemoglobin A1C, blood pressure, fruit and vegetable intake. And this is all toward generating a replicable and scalable food economy model to reduce obesity and improve diabetes. And this is something we want to help scale across the country. This is a theoretical systems map representing the interconnectedness and mechanisms of this intervention and the influence. And I wanted to show you to really underscore that this is complicated. It's not just telling someone how to eat. It's not just growing fruits and vegetables. It's not just telling a healthcare provider that they should deliver education. It's a lot of systems that are interacting simultaneously. So from the individual in their own household consuming fruits and vegetables, to the larger food system, to policy and governance, to local people on the ground who form food policy councils, and then healthcare. And these things need to really work well together, which is why coordinated community-based participatory interventions are really important to do, so we see how we can make them successful in the local context and then scale those up nationally. So I'm going to end with areas that I think need further exploration for food as medicine interventions. They're really exciting areas, and there's a lot of work going on in the country to address these. The first is behavioral science, really understanding motivators and barriers to dietary change. This is at the individual and household level, using different theories to make sure that we are developing interventions that will be successful. Community engagement, this includes partnering, collaborating, and co-creating with community-based organizations, communities, and patients. So there's ownership and programs take root at the local level. We need more work on implementation science so we can evaluate reach, adoption, effectiveness, maintenance, and scale. We need to invest more in agriculture so that it's climate smart, regenerative, and context specific. We need to study economics and sustainability so we understand the costs, the packaging and delivery, the food waste, the pricing, and the labor capacity. We need farm capacity where there's infrastructure, technical assistance, training, people are provided a living wage, and this is through different mechanism of grants, funding, and investment. Policy and advocacy, where there are reimbursement policies put into place. There's advocacy for food as medicine integration into healthcare. And then healthcare integration, really implementing food into healthcare isn't as easy as one would think. It needs to link with the electronic health records. There needs to be streamlining of referrals, and this includes seeing registered dietitians who are our excellent workforce across the country who provide nutrition education and prescription for people. And really embedding all this work into the clinical workflow is extremely important. Getting that right is something we need to study more. Training healthcare professionals, this starts in school, in medical school, in training all of our healthcare professionals that go out and interact with patients, and then make sure through continuing education that they're kept up to date. And then, of course, cultural tailoring and relevance. We have a lot of different populations that live across the US, and we want to make sure that we are adapting interventions to specific cultural preferences so that these interventions are successful for all Americans. Thank you very much, and I look forward to your questions.
Thank you, Christina. That was terrific. I also want to note that it's a very busy time in Washington, and yet we have almost 130 people on today's call. So this is obviously a concern of many.
Yeah, I'm really glad
yeah.
to hear that, and I'm excited to take some questions and keep in touch with people. And just to say that nutrition research is extremely important, and I think there's a lot of support for that across the country. I know that many of us want to see pragmatic work done that can quickly be brought to the American population.
As you know, Christina, Research America, in partnership with the American Heart Association last year, sponsored a national survey on nutrition. And cost was by far the biggest barrier that respondents cited in terms of eating healthy foods. How does food as medicine, how can the food as medicine as a policy goal, how can that address the cost barrier? And in fact, one of the questions that was asked, I think, gets at that even at a deeper level. With the food as medicine model, do you anticipate that with prescribed diets, insurance companies will collaborate with programs like EBT and SNAP to ensure that end users aren't excluded from participating due to the expense of quality food? So where does cost come in terms of the food as nutrition, food as medicine model?
Sure, sure. So let me just say, most people conducting studies right now are looking at cost. They're looking at cost at every aspect. Economic analysis is really important. We don't want to do this work and then assume that it can be institutionalized into our systems without understanding the cost. So that's really important. I didn't have a chance to talk about food insecurity, but it is important for everyone to know that about 34 million Americans live in households that are food insecure. So they're uncertain of having or unable to acquire enough food to meet the needs of their household members. And lower food insecurity is, of course, correlated with nutrition security. So it's not just low food, it's low nutrition security. And that's just important for everyone to know. And reiterating what I've said already, that healthy diets are essential for achieving food security goals and improving nutritional outcomes. So let me just talk about cost in a number of ways. At the individual level, there are things people can do to think about cost in consuming a healthy diet. And I'll just go through a couple of recommendations, and that includes, planning meals and shopping lists. There's a lot that people can do to be creative. There are a lot of healthy foods that are less expensive. They do often require more time to prep, but there are ways that people can build that into their weekly routines to make sure that they are shopping with a purpose and then getting those foods into their household. There's also ways for people to shop smart and buy in bulk. There's plant-based proteins that are on the rise, which are often less expensive. There's strategies people could do in their home to mitigate food waste, which is a very big problem in this country. And then there are other things people can do, like cooking at home. We expend more than 50% of our food dollars outside the home, and the more people can consume at home, the further their dollar will go. And then we need to look at fiscal policies, and that might be taxing unhealthy foods. There have been experiments done with, for example, sugar sweetened beverage taxes, where those funds then go to public health programming, subsidies for healthy foods, particularly price discounts for fruits and vegetables. I mentioned already the GusNet program, which is part of the Farm Bill, that actually incentivizes folks who are on SNAP to consume more fruits and vegetables through incentivized purchasing. And then there's questions about removing taxes on healthy foods. So a lot of this has been discussed. At the policy level, there's a lot we can do with menu labeling and zoning laws and healthy food procurement. So I want to take a minute to talk about all of that, because it's all of it. It's not just making sure that a program we implement is economically viable to scale. It's thinking comprehensively about how we address the cost of food in this country. I could talk a little bit more about farmers in America and how we need to support those more in order to grow specialty crops, which are fruits and vegetables. And there are lots of areas in this country where people are investing more in fruit and vegetable production, and that is year-round, including hydroponics. And that's a national security issue. So the more we can do that, and the lower we can make the cost with respect to food miles and local fresh food, that again increases jobs, I think is really important to think about.
Are any payers right now uh, paying for food?
There have
Food
been
insecurity?
waivers. They're called
Mhm.
1115 waivers through the Medicaid program. And these are right now
Mhm.
in 12 states that are experimenting with food as medicine and collecting data, as I showed before, on health outcomes, economic analysis, feasibility of implementation. And these are the studies that we're seeing published right now. I believe North Carolina had some data out recently. I know Massachusetts will, on really showing the benefit and the economic impact.
Okay, great. Well, we have lots of questions in the Q&A, and then we also had some questions that were submitted to us previously. So I'm going to start with those. What are some strategies that community health centers and others engaged in primary care can utilize to control rates for chronic conditions such as diabetes and hypertension?
Yeah, I mean, I'll speak about it from a food perspective, and I'll start with just training. So a lot of people who are practicing were trained a long time ago, and yet healthcare providers need to participate in continuing education. And so I would say, as the data emerge in this area, investing in continuing education for physicians and nurses and dietitians so that they're up to date on the benefits of integrating food or food-based interventions within healthcare. So that's something really important to do. And then it's really an organizational decision about investment. But I think if people can really embrace the concept of paying now rather than paying later and looking at all the data that demonstrate there is a cost savings, I think making that decision to institutionalize, food and nutrition from an education perspective, hiring a dietitian, making sure that everyone is up to date on the most recent evidence and are comfortable talking with patients about it, and then adopting, food as medicine interventions. If there's no mechanism for doing that, there are still lots of ways to connect people with local resources. And those local resources include the federal policies I've already talked about. So that's our SNAP program, our WIC program, where people are income eligible to be on those. Most communities have food banks. There is, a large effort in most cities to make sure that food is available for people, community meals, et cetera. So I think community health centers can also make sure that their resources are up to date and they're making appropriate referrals for people to get connected to food-based programs.
To what extent are the food as medicine approaches being adapted to educate young people?
Do you mean young people like K through 12?
Yeah, K
Yeah.
through 12. Yeah.
Yeah. Well, I mean, let's step back and think about what we teach in our schools. We do know that oftentimes what we teach is what students are tested on. So until we have standards where young people need to be competent in nutrition and physical activity and lifestyle and wellness and strategies that will help with longevity, it's hard to incorporate those into the curriculum. So it's not standardized nationwide. That is a decision that's often made state by state or community by community. I would advocate that educating young people goes a long way. And I know that from many interventions I've done in the K through 12 space, where even years after I hear from people who were participating in the studies who really valued what they learned and it influenced their behaviors. So I think we have to think about it as what we value is ultimately what we're going to then hold students accountable for in testing. And it's smart to think about making sure that we incorporate that into our educational system. So I think it varies quite a bit.
I'm going to go back to audience questions, but we've been doing some research that will be public in a few months on Gen Z and how Gen Z looks at science, and they have an enormous interest in nutrition.
Yeah. Well, we see that.
Yeah.
They
So,
absolutely do. And,
yeah.
I think there is an enormous amount of information available to them on social media. And we need to make sure that they're getting the best information possible and it's being delivered to them in a way that's consumable. So we can't assume they're going to download fact sheets off one of our websites. But they might look to someone who is on social media informing them. And I would advocate that we try to get evidence into everyone's hands and make it appropriate for their different stage in life.
Absolutely. All right, let's see. So Eric writes that he's on a Ground Foundation board, which serves rural health benefits. And they've been getting more requests for community gardens and the utilization of healthy foods. So does your study suggest long-term health benefits from good nutrition?
So let me back up and say epidemiology is really the area we look to for long-term benefits, where people are enrolled in studies and they're followed for many years and their lifestyles are documented as well as their disease outcomes. Most studies that we're conducting in the intervention space don't really go beyond a year or two. Intervention work is extremely expensive. You need to retain people in studies for the entire year or two. And so we have outcomes at that level. Sometimes people are followed 5 or 10 years later to see if the behaviors and the outcomes stick. but we know most of the long term, meaning somewhat decades, like the Nurses' Health Study, for example, which is a large cohort that's followed over long periods of time. And in that case, there's no question that dietary intake has impacted disease outcomes in individuals. That's how we know a lot of the recommendations and how they're informed, because we see people's lifetime of consumption impacts their health and disease outcome. So I would say the interventions that we do are really striving to catalyze a movement in a particular area and to adopt those into policy. So when you have good interventions that then become policy, it enables the population to continue with that behavior and practice for decades. So that's really how we think about intervention research and how it informs long-term health.
Well, I know we're all concerned about, recent cuts to NIH and FDA and how that might impact even your research. I'm going to pivot to another question because I'm assuming you don't have the complete lay of the land there yet. Um, uh, Around the current administration's interest in chronic disease, and to what extent food as medicine or nutrition is part of their strategy.
Yeah. I mean, I'm really excited about it, what I've seen so far. And as you said, there's information that's coming on a daily basis, but it's still fairly new. But what I'm seeing so far that's been presented on HHS and other websites is that there's a really big commitment to nutrition. And I think collectively, we can make a sizable dent in the health of the population in a fairly short amount of time if we adopt some of these strategies. I've actually seen food as medicine lifted up. I know for sure that Congress is discussing it. I know there are a lot of advocates and again, saying that there's bipartisan support. So I think there's a lot of work going on now to restructure and to understand the direction that we should be moving in. But I'm looking forward to the next couple of months when the strategies start to become clear and we're able to really have a loud voice in terms of the evidence that we've generated and how we can advise and help move forward over the next couple of years. We see from studies, a 12-week study, a 6-month study, you can see meaningful changes in blood pressure, hemoglobin A1C, body mass index. This won't take 5 decades to see individual health changes. This can be done fairly quickly, and to institutionalize it across the population, we can really work on that over the next few years. So I'm looking forward to it.
Audience question: how can the field create clear standards for food as medicine to ensure that the approach and even the terminology isn't co-opted for
Yeah.
profit in a way that wouldn't serve public health?
Sure. So there are a lot of organizations right now that are focused on food as medicine. We have an institute at the Friedman School, and we have an annual summit where we convene lots of people working on it. And there are funders like the Rockefeller Foundation that are helping to standardize measures and terminology, et cetera. So there's a lot of work going on right now. I would also say if we had centers of excellence that were funded by the NIH and by other government agencies, that would be really helpful, because historically, if you look at different initiatives that have been done or different diseases that have been tackled, when you have centers of excellence, it really provides that mechanism to do exactly what you said, to standardize measures so you can roll up the data and look collectively at the outcomes in different studies, to look at the methodology for data collection, and you can say a lot more. So I would advocate for standards of excellence in food as medicine at the national level.
All right, terrific. So there's an interesting question about how medication and nutrition interact. This person is concerned about gout. So he's the co-founder of the Gout Support Group of America. And, he's saying that while food can support overall health, it can't replace medication for many.
Sure. Right.
And he wants to know, what's your perspective on the next frontier in public health for conditions that sit between nutrition and rheumatology?
Oh, that's a great question. Just full disclosure, I think everyone knows I'm not a medical doctor, and that is
Mhm.
not my area of expertise. So I'm going to answer this very, very generally, but I have worked on many of my studies where individuals have either risk factors for or heart disease, diabetes, and are under medical care in addition to uh, the study that they're participating in, including the one I mentioned already that I am conducting, where the participants are being seen for their health care at a health center. So, what I really believe is there is power in both prevention and treatment. And I think that comment is really important, that there'll always be a need for medication for certain conditions, but can we enhance outcomes? And I didn't talk at all about personalized nutrition, which has been a big effort from the NIH. And this is an area of research where we're really trying to understand not just population recommendations, but how do we work with people at the individual level? And this will be taking things like DNA and microbiome into account when we start to prescribe diets. So enormous amount of work going on. And I think it's relevant for the question because there may be variability even within the population that has gout, but there may be specific nutrition recommendations that work well with medications, that work well as people decrease their amounts or increase their amounts. And this is really a new frontier that we're all excited about.
So speaking of variability, there are, there's a big element of culture in food, right? So food selection can be very specific to different cultures. How does the food as medicine model work with those important cultural differences?
Yeah. So I talked already about the community-based component of any of this research and how important it is to have voices and lived experience from people who are receiving the interventions. So let's take medically tailored meals first. There are lots of interventions that are happening where people are surveyed to understand what are the recipes and what are the foods that you want incorporated into the medically tailored meal that you're getting. We have an excellent organization right in Boston called Community Servings that's doing a phenomenal job with this. So there are ways to create meals that are culturally relevant for different populations and take into account the sodium and potassium and fiber and saturated fat levels, just as an example, that are relevant to treat disease or prevent disease. So I think that's where dietitians and not just food as medicine, but culinary medicine comes into play, which is another really big movement across the country with teaching kitchens, making sure that those are institutionalized into healthcare training, and then they partner with chefs to really make sure that's happening. So there's a lot of great work going on in culinary medicine and teaching kitchens, and I would say that's how this is happening. Community voice, paired with expertise.
Are school meals another opportunity, sort of a
Mhm.
living classroom to educate youth on the role of food and health?
Yeah, I've done quite a bit of that myself in my own interventions, and it's been very successful. There's no question when you bring food to children and when they grow it or they're able to taste it and prepare it, they eat more. Everyone has shown that. So the more we can do with education that complements the school meals program, the more children are going to enjoy that food and hopefully replicate it outside of the school in their homes. So there's a lot we can do there, and there are, you know, um, I'd say gems of programs across the country that have been doing that for a long time. Alice Waters helped to pioneer some of that work. So we really need to continue to make investments there because that generation is the future. And as you said, from the study you're about to publish, they are heavily invested in food. They care about it from different perspectives. They care about disease prevention. They care about the population growing by another 2 billion by 2050, and they recognize we need innovation like cellular agriculture, plant-based proteins, a lot of different things that are going to be necessary to feed the planet. They care about taste because everyone does, and they care about climate change. So you put all those together and you can see why there's a big investment in food
Mhm.
within the young population.
Well, we have many more questions. We will share your slides. I'm
Okay.
assuming that's okay to
Yep.
distribute your slides. Terrific. And I love your background too. I'm a big
Well, thank
carrot.
you.
I'm a big carrot eater. So And I love green, but it goes so well with your work. Thank you
Thank
so
you.
much, Christina. I've learned a lot.
Oh, good. Thank you.
Uh, and we're so pleased you could join us. Before we end, I just wanted to remind everyone that if you're with a Research America member organization, you're invited to join us for our next Alliance member only meeting on next Wednesday, April 9th at noon. So by popular demand, Cheryl Yeager of Crossroads Strategies and Carrie Wallenetz, PhD of Lewis Burke Associates, will join us, and hopefully you, for a very interactive discussion about the latest developments in Washington.
Jenny,
So
can I say one more thing as we
yes,
close? And
please.
that is that everyone on the call and everyone they know has a voice. And anytime you see something or hear something you want to weigh in on, you have two senators and lots of people in Congress, and they want to listen. So please use your voice when you want to advocate. Thank you very much.
Thank you, Christina. That is very much a Research America motto. So I'm going to say goodbye to everyone, and we look forward to seeing you again soon. Thanks.